Hello, everyone, and thank you for participating in today's webinar. This is a webinar sponsored by Hands-On Diagnostics, and we have with us some very knowledgeable presenters that will tackle the issue of billing of telehealth and all of the different updates that we need to have about how to properly bill physical therapy services in telehealth, whether the patient is a Medicare patient or any other type of insurance. Before I start with the presenters, I would like to share with you very quickly an amazing initiative that we have started just recently. It is the initiative of PT for Heroes, and this is a movement of physical therapists across the country, across the nation, where they are helping to provide free telehealth care to our healthcare professionals, the doctors, the nurses, all other healthcare professionals who are standing on the front lines of COVID-19. This is an initiative of Hands-On Diagnostics, but as you will see here, it's being supported by many other organizations, and we have also many physical therapy practices that have already participated. So I am inviting you to really get to participate in this very important cause. Also, there is information here on how you can promote it. If you go to resources, it will give you a lot of information how you can support this effort, promote this effort, and really make this a movement that will elevate the physical therapy profession at a level where this profession can help other healthcare professionals who are standing right now in the front lines of COVID-19. Also, I would like to remind you that we have the webpage savephysicaltherapy.com, and in this site you can find not only information about our upcoming webinars. The next one, for example, will be the 5 mitigation strategies for your physical therapy private practice right now, which is an online event. We have also the forum, the town hall, which is happening once a week now, every Thursday, and starting this week, and for the remaining 8 weeks, we will be discussing every week the 8 key points that a physical therapy practice must implement for a speedy road to recovery. Also, this webinar, tonight's webinar, along with all past webinars, are on the past webinars tab, where you can access everything that we have done for the past month and a half now. And of course, under the tab resources, you will find not only previously uploaded resources, but also today's PowerPoint presentations. You'll be able to find them also under resources. With no further delay, I would like to introduce today's speakers. And first of all, I would like to introduce Mary Dualong. Mary is an expert in the area of physical therapy, practice, compliance, and billing and business operations. And she is the owner and president of BCMS, Business Clinical Management Services. And also we have with us Bob Kowalik. Bob is the founder of, let me get the company right, Certified Reimbursement Solutions. And he has brought with him Jeannie, who is one of his managers, and I think Chris also. No, just Jeannie, right? Who will be offering also some insights. Okay, fantastic. So what we're going to do is we will start first with the essential points of how to build telehealth. What are the different types of telehealth and how you can build accordingly each type, and what are the latest updates we have from CMS and other insurance organizations in regards to the billing of telehealth. We'll start with Robert on that, and then we'll discuss with Mary more on the compliance part. So Bob, take it away.
Thanks, Dimi. And thanks to Hands-On Diagnostics for all you guys are doing for, the physical therapy profession through unprecedented, times that we are in now. And Jeannie is an operations director with me. And so when we get to some of the coding specifics, Jeannie will kind of take over. I'll still operate. But I do have some slides that we'll run through, and we'll just kind of open it up for questions. I'm happy to stop for questions and clarifications as we're going through. If you're monitoring a chat, it'll be a little difficult for me to do that at the same time. So if you want to just kind of give me a heads up that you'd like to ask a question.
Bob, one quick second before you share your slides.
Yeah.
Let me just say two quick things. One is that I'll work with Mary in a moment. I know that you cannot see her right now. I'll work with her. So there is some technical difficulty. However, I have a specific poll that I would like for you guys to answer, and I'm going to launch the poll right now before we get to the actual presentation. So this is the poll. The first question of the poll is your practice still open or closed? You can select open or closed. That is the first question. The second question would be, have you implemented TelePT, telehealth, telerehab, any kind of tele thing? And the third question is, what percentage of your current visits are telehealth? Is it 0? Is it 1 to 30%, 31 to 50%, 51 to 70%, or greater than 70%? So that is basically the poll. If you take a moment to answer, it would be fantastic. These numbers, it's great information to share with everybody in the group so that you get the pulse of the nation, and we have a whole bunch of practices tonight, so it's a very good representation of what's happening across the country. Okay, I am going to close the poll in 3, 2, 1. Any suppressed votes? Okay, I'm closing the poll. All right, end of polling. And I'm gonna share it with you guys now. So based on the results of the poll, we have 73% of the practices are still open, 27% of the practices are closed. That's a very good number, actually, better than I expected. Have you, and like along the same lines with the previous survey we had done that showed 70% of the practice is open, have you implemented telehealth? 65% of the people say yes, 35% of the people say no. The survey that we did 10 days ago, it was 50-50. So we have more of a shift, 15% change in the movement towards telehealth the past 10 days. What percentage of your current visits are telehealth? 35% say nothing, 47% up to 30%, and then we have about 8% of you that are doing more than 70% of telehealth. God bless you. That is really awesome, really fantastic.
And this is interesting, Dimi, because this is the second line. It's very realistic. And it seems that although telehealth is the easy thing that everybody can do it and that it's an easy process, it's not, for me, the biggest barrier is the customer, because the customer is used to manual therapy. So it will take some time before those customers, our patients, really see the positive or the idea of getting treated, through a video.
Yes, that's exactly right. So with these numbers in mind, Bob, go ahead. Unmute your microphone.
There we go. Sorry.
There you go. And share.
Yeah, I will share screen. Can we see that? Okay, good. So it's great that you guys have a good percentage of you have started down this path already. A fair amount still have not, and it seems like a lot, the majority still have not done it a whole lot. And so, we have clients, in 30 states or so, and we have clients in various stages of implementing, virtual services. All of our clients prior to COVID-19 were a brick and mortar clinic, location type providers. We didn't have a single client who was only a virtual services provider. So we have a variety of adoption across the board. We are billing it every day now. So we will talk about our experience with that. And we do have one client who has managed to move 82% of her clinic visits to virtual services. So at some point, we'll figure out a way to get her connected to you guys and talking about how her success with actually doing that kind of transition, because it's pretty remarkable that she's 82% operational with virtual visits and being paid for it. Her practice is in the state of Washington. So Dimi mentioned our name at Certified Reimbursement Solutions. That is our name, but we're also co-branding Revenue Cycle Solutions. We're in the middle of a branding change, which really represents our evolution as a company from just a billing services focus to really a revenue cycle focus. Anything that impacts if, when, and how you're paid is something that we're touching one way or another with clients. So it's it's just a technicality. We're legally both. I am the founder of the company. Jeannie is on with me. She's an operations director. She used to run, I was a private practice owner. We had a private practice that did about 10,000 visits a month. And Jeannie ran my entire billing operation when I had my private practice. So she's been with me for, I don't even know how long, a long time, 25 years or something like that. So my goal for this presentation today is to provide some updates with what's the state of virtual services for private practice PT, improve your understanding of the types of services that are applicable, provide some general guidance on the billing and coding, and look at some strategic considerations for how you roll this into your practice, and hopefully save some of you some time. So just a quick point here for context. So this coronavirus, COVID-19, has just had tremendous impact. These are some statistics on unemployment rates, and from this the Chamber of Commerce, what's expected in terms of small business closures across the United States. So in the last 3 weeks, 16 million Americans have filed for new unemployment claims, and they're thinking that unemployment rates could go over 30%, which would be a new record for this country. So this is a huge problem. It's not only an employment problem, but it's creating huge liquidity problems and survivability issues for practices. They believe that 11% of all small businesses are less than 1 month away from closing. 25% are less than 2 months away from closing. We're talking about permanent closing here. 3 to 6 months away from 43% of the businesses closing. And then 54% of all small businesses are already temporarily closed at this point in time. So this is an enormous problem that we're facing. So our challenge as a business, and we have the same challenge that our provider clients have, because essentially if our provider clients don't get to the other side of this gap, then we don't either. So the strategy for this really is in what I call top line revenue preservation. So you've got different moving parts here to your business that all have to be addressed. But I believe the most significant, and I've been collecting data, I'll talk a little bit just briefly about this at the end. I've been collecting data from practices around the country on whether or not they're implementing the PPP loan program, how that loan fits into their COVID-19 plan, projecting what cash flow looks like for the rest of 2020. And I can tell you that the biggest single factor in how much of a bridge the PPP loans build for people has to do with how much top line you're able to preserve in your business. The average practice right now across the United States, we've got data on about 150 different practices as of today, expects that they'll lose about 2/3 of their revenue before the patient volumes start to return. So that's a pretty deep gap that's going to need to be bridged somehow or another. So the strategies for preserving top line revenue really are, first and foremost, you've already generated claims that are out there in accounts receivables, and you got to make sure that you convert those to cash as much as possible, because that's money already out there that's waiting to be deposited in your bank account. And then, it's great to see that 2/3 to 3/4 of you are still open and seeing visits, albeit probably a much less volume of visits, but any kind of maintenance of traditional in-office visits is a huge contributor to the sides of the bridge that you need. And then, we're really looking at for our traditional kind of practice as virtual services being a new implementation model, something to add a revenue stream with. And I believe this is where most practices see this fitting in. It's adding new opportunities for top line revenue. Not going to spend a lot of time on the other things here, but reducing cash or expenses, decreasing the cash burn is a huge thing as well. But we have to be really strategic about how you do that with regards to people in the context of whether or not you plan on using PPP loan funds, any kind of emergency disaster loan scenarios. All of that's kind of integrated. So number 2 and number 3 are critical. But our focus really here today is how we support top line revenue through implementing virtual services.
Bob, before you move on for a moment, because I'm getting this question several times from people right now, and the question is, there is a little bit of worry with some people because, hi Mary, you're back.
Yes, but then under my desk.
Oops, okay, turn off that phone. Okay. So what people are asking essentially is what happens to those individuals who did not receive on Friday, this past Friday, HHS money, the Medicare money. It seems that several practices received the HHS money on Friday, and then Monday or today, Tuesday, nobody that we know of indicated that they received any HHS money.
Yeah, I've read that it could take as much as 10 days for everyone to get the funds. That a lot of the funds were released on Friday, but that was not all the funds, and they released it, and I'm not sure what kind of pattern that happened in. If you are paid, and I don't even know who today is not paid electronically from CMS, but if you had an electronic payment method in place, you were supposed to get an ACH deposit whenever they do transfer the money. So
did you say you don't know anyone that has received money yet?
No, I don't know of anyone who is paid by check anymore from Medicare.
Oh, I meant from.
Yeah, I would say about half of my clients actually received the ACH deposit on Friday.
Right.
It was 6.2% of your 2019 Medicare reimbursement, but it was Medicare without any MCO or Medicare Advantage plans. So it was that was the formula. They gave you the formula, but the way that they presented the formula was kind of goofy. It's 6.2% of 2019 Medicare reimbursement. So
you said 6.2%.
6.2%. Yep. And it's not your Medicare Advantage stuff. So it's Medicare. So that's what you should be looking for. I wouldn't panic yet. They said it could take as long as 10 days for it to all happen. And if for some reason you're paid by check, it could take 2 to 3 weeks to get a payment. So it was supposed to be delivered through UHC, somehow through Optum. It was some pathway that they created for electronic transfers, but it was ACH deposit, not EFT. That's what I know, and it's not everybody got the money, but everybody that was a Medicare provider should have gotten their proportionate amount of distribution on that. There's a terms and conditions document that is readily available to look at, and I believe that there's some the APTA is looking for guidance on getting an absolute determination as to whether or not PT private practice was supposed to get the money, but every indication that I see is the answer to that is yes, that you don't have to treat patients for COVID-19 for this extra payment. You just have to have been affected by COVID-19 and see patients who could be infected with COVID-19, but you don't necessarily have to be a frontline healthcare provider that's treating COVID-19. And they've asked CMS that very question. They've gotten an unofficial response that that's what I said is true. But if you're holding on to, if you received these funds, my recommendation is before you go out and spend them, maybe just set it aside for a little bit until we get some final rule on whether or not you have the green light with this. And then you will have to go through and sign the documentation that you do. There are a few strings attached to it. Most of it is that you're not going to use these funds in any kind of socially inappropriate way. But for the most part, it's it's that kind of thing that are conditioned. So that's everything I know about it at this point.
All right, thank you.
Okay, so obviously, virtual services are encounters that a provider and a patient have through some kind of digital communication platform. And it's all over the map on who's paying what, how. It's evolving still quickly. I believe we're up to 37 states now that have parity rules in place for the use of virtual services. But you do need to check, and we do have some resources and a link in this presentation which will be made available to everybody for where you could go and actually check the state of things in your specific state. So we'll get to that. And then these are the two resources that you can go to. CCH PCA seems to be a great source for looking at real-time state updates on the status and the laws and the rules and the parity conditions and all that kind of stuff. So these two links will, wherever you happen to sit, will help you sort that out. So there are four kinds of virtual services, fourth being telephone calls, but I'm going to separate those out and really talk about the three main kinds here. Telehealth, virtual check-ins, and e-visits. And this is how they really play out. The main differences here is telehealth, you have to have real-time audio and video for it to be considered telehealth. Whereas in virtual check-ins, it could be either or. It could be audio and video. It could be just audio. I don't think just video works in any scenario, but you could have, text, email, those kinds of things, patient portals, all of that could be applied in virtual services, where e-visits require audio and or video as well, but you can't do e-visits through text messaging and email. So the main difference is that on the two sides, telehealth and e-visit requires a real-time interaction between patient and provider, whereas in the middle, the virtual check-ins are asynchronous, could be asynchronous or synchronous encounters. So telehealth is for new or established patients. The other two types of services are for established patients only. And in a telehealth visit, you can do an initial evaluation and assessment on a new patient or on a existing patient. Whereas virtual check-ins and e-visits are more for follow-up types of communications with already established patients. And there's a little bit more direction on that. But in a telehealth visit, let's say you're doing a 97110 type of procedure code. The idea is that you could accomplish a very similar outcome in a telehealth visit that you would or could in an office visit for the same types of procedures. For a virtual check-in, the main purpose for those is to decide whether or not an office visit or some other service is really needed. And in an e-visit, you want to make sure that there is some clinical decision-making being accomplished during the visit. The telehealth is initiated by either a provider or a patient, whereas e-visits and virtual check-ins are initiated by the patient. And telehealth is billed on on each encounter for the CPT codes that you would be billing in the units, similar to what you would be doing with an in-office visit. Whereas a virtual check-in is also a per encounter billed type of service, but it's a brief encounter, typically between 5 and 10 minutes in duration. An e-visit is a little different in that it's billed only once a week to cover a 7-day period. It's cumulative time over that 7 days. So those are the differences between the three main types of virtual services. So I'm gonna have Jeannie kind of hop in here and talk about the coding thing. Can we see if Jeannie's on and can speak?
Yes, she's on, and Jeannie, I'll unmute you right now. Actually, you have muted yourself, so you need to unmute so you can be able to speak.
Okay, can you hear me now?
Yeah.
Yep.
There you
Okay, hi everyone. Yeah, as Bob said, with the telehealth, you would typically use the codes that you do in your office. Some carriers are not covering 97530 and 97140, so that's a question you should ask when you do your insurance verification. Then the telehealth check-ins, again, it's just a brief check-in with your patient. You don't have to hold your charges and submit them over a 7-day period. You just bill it as it happens. And I don't know what the reimbursement is on that. I couldn't find anything. But I'm sure it's not much.
Yeah, I think what I saw was around $28 or something like that.
Okay, yeah. And then you have your e-visits, which are based on a 7-day period. You can file your claim.
Yeah, and the 5 to 10 minute code is about a $13 reimbursement. The 11 to 20 is about $25, $26, and then 21 plus
Right.
minutes is like $35 or $36.
Right. Now there are and there have been phone call codes that have existed for a long time.
Yeah, let's not get to that yet. That's on the next slide. Let's go through box 24 and B and D and all the modifiers and place of service and that stuff.
Okay, does any, place of service is 11 for the virtuals check-in and the e-visits. I know there was some other information put out by Medicare early on, but now they're saying to use the place of service 11. That's the most recent thing that I've heard. And for the virtual services, more of the insurance companies are telling us if you're using the e-visit code or the virtual check-in, you don't need to use a modifier because the code itself tells the insurance company what's being done. I actually got a denial for a Medicare e-visit that was billed with a GP modifier. The representative told me not to put it on there. So we're just watching the EOBs very closely and making adjustments as we see how the payers are processing things. A lot of these questions can be answered in advance if you get a representative from the insurance company that knows the answers to the questions, or sometimes they can refer you to their website.
Yeah, and we are going to talk about in a minute here about the verification process for that and questions. And we've got a form that we developed for this as well. So we'll get to that in a minute.
We got a quick question that I'm gonna ask on virtual check-ins. Somebody says, does that include if a patient makes a phone call to ask a question about their care? Does that have to be disclosed to the patient prior to transferring the call to the provider? So in other words, she's saying, he or she is saying, can you use a virtual check-in initiated by the therapist to just check how are you doing? How are you feeling? How is your care? And pay for it.
Yeah, maybe Mary knows, but what we've seen is that the virtual check-in is something that is typically initiated by the patient and then followed up with by the provider. So you can have a back and forth conversation that might not be totally in sync, but generally it's a patient initiated type of thing and the encounter is really about sorting out whether or not you really need to see the patient in the office or do some other type of testing or service. That's what we know about virtual.
Can you hear me?
Yeah, hi, Mary.
Hi, I'm sorry. I'm working with 2 different computers and I've been under my desk. So I don't know what it is about this, but I keep having computer problems when we do these sessions. So please forgive that. We are supposed to have the patient initiate all of those virtual services. However, they are cutting us some slack. HIPAA is cutting us some slack. The CMS is cutting us some slack about if you have good faith effort that you need to get to the patient isn't aware of the service that can be provided, then they're gonna, I don't wanna say look the other way, but it'll be a light slap on the hand if it's anything. So that is for e-visits, for check-in, virtual check-in, and as well as the telephonic
Yeah, the telephone thing. The one that's different is telehealth. To telehealth, you can,
Right.
it's like you can see a new patient that way, right? So not even an existing patient. So it is, outside of telehealth, it is intended that the patient initiates the need for the encounter. So we also have, we do know that CMS has recently added PT and OT as for virtual check-ins and e-visits. They did not add us for telehealth, so you can still see Medicare patients under the non-covered services rules and bill a patient. But we do have a reference for the addition of check-ins and e-visits to PTs. It does not seem though that telephone calls were added. We can't really find anything there related to CMS and telephone calls. And so on telephone calls, these are the three codes similar to the e-visit timeframes. What's Jeannie, do you know, or Mary, do you know if we're talking about, is this within a 7-day period as well, or is this per call?
Yes, both of them.
Okay.
So you can't have had a visit for 7 days and then you can't initiate another contact for 24 hours.
So a kind of, in terms of strategy here, right? If you don't mind, can you go to the previous slide for a moment, Bob? Until this moment, we do not have really a true telehealth solution for Medicare patients. It is possible either this Thursday on our town hall at 1 p.m. Eastern, or next Thursday at 1 p.m. Eastern in our town hall. It is very likely that we will have the Director of Government Affairs of the American Physical Therapy Association discussing this very issue and the efforts that the APTA is doing and has and is planning to do to get us full telehealth. I'm working with Justin to manage to get him on that meeting, and we'll keep you guys posted. That would be either this Thursday at 1 p.m. Eastern in a town hall meeting we're going to do, or next Thursday, and you can get information at savephysicaltherapy.com.
Awesome.
Yeah, there is a question to everybody. Somebody says, can we provide telehealth treatment to a patient who currently is not in New York State? I guess the therapist is in New York State licensed physical therapist. The patient is outside of New York State, and Serge is asking if he will be able to provide telehealth services to a patient who is outside of New York State.
I believe the answer is yes for now, that the state orders kind of were taken down by CMS for this, but you know, like many things, a lot of these changes are temporary and conditioned on the 1135 waiver, which is the public health emergency. So just you got to keep track of what you're doing when and when these types of lax regulations are moved back to normal.
Well, I think we also have to consider state practice acts and the compact. If there is a compact existing between where the patient is and where the therapist is, and the therapist, wants to perform a virtual service, then possibly, but they have to look at the Practice Act, because if the Practice Act doesn't allow it, then, you can't do it. And also some states do not allow it. So if the states don't allow the crossing borders, then you're not able to deliver the service in another state.
So what do you do when it's a Medicare patient and Medicare says you can for an e-visit, let's say? I'm not sure how that would work, not being an established patient, honestly, but it probably doesn't even apply.
Well, you always defer or yield to the most stringent. And so in this case, even though it's a federal government, the Practice Act and state law, if the state doesn't have a waiver like the feds have, then you're going to have to go with the most stringent interpretation, and that would be you can't do it.
Do we know how many states have that kind of interpretation?
Geez, the state governments, I would have no idea.
Yeah. It'd be interesting.
And we don't have that many states in the compact.
Yeah.
So it's kind of far and few between.
I have a question about direct access. Is direct access in effect right now or no?
I'm sorry, are you saying can we use direct access right now during the pandemic?
Yes, because
Certainly.
there is a question. We can, right?
Certainly.
Because there is something about essential therapists, and that's also chiropractors. They cannot do direct access or something like that. They're totally restricted in a way because of the pandemic. Anyway, it's something that we have to look into that further.
Mm-hmm.
Let me make a comment about that because something that happened in New York State, it started becoming national news, and people started getting a little bit worried about this. So what specifically happened in New York State is that initially physical therapy was not listed as an essential service. Subsequently, there was intervention by the New York Physical Therapy Association, and the governor came with a clarification that indicated that physical therapy is an essential service. Later on, there was an update, and they listed physical therapy essential service with doctors with a medical prescription. Okay, so everybody then started worrying that, hey, this is taking away direct access, and maybe this is an effort from the system across the country to start taking direct access away. So the New York Physical Therapy Association spoke with the governor, spoke with the Department of Health, and basically what they are saying right now is that telehealth visits do not need a physical therapy referral. Physical visits in an office, they might need a prescription so that you can make sure that if a patient has symptoms for COVID-19, they are not coming to your physical therapy office being sick. So that is like the latest update that I read about that. But there is no problem or fear of taking away direct access or anything like that, because there was some communication, and I started receiving texts from people panicking about this. So
it might be just for now.
That's correct.
That period of time, for the pandemic period of time. Okay.
That is correct.
And I do believe that HHS considers physical therapy essential services
yes.
part of healthcare, but you do have under these shelter-in-place rules that the state governors can trump that and basically say you are not for this, for this purpose. Like that's the case in Michigan, where they've said unless you are directly involved in the preservation of life, you're not essential services. So though we have lots of practices that are still open in Michigan, as long as they still have new patients. So it is very confusing.
I think the most significant statement was made by Homeland Security, and it specifically addressed physical therapy and the critical need for physical therapists to keep their doors open so that they could keep the patients out of the hospital. And it was very, very moving statement. If y'all haven't seen it, we can get that to Demi and then share it with you, but it is a quite impressive statement.
Yeah, definitely. Let's get that and we'll disseminate it.
Okay.
Also, some very quick questions so we can move on. I just got a response from CMS on my recent bill for e-visits. They denied the claims for reason 16. I used modifiers GP and CR for the G code G2063.
Yeah, Jeannie, I think that's what you saw, right? Can you speak to that?
What I saw was it was denied for using the GP modifier, which you add on to all PT code. There is something that came out by CMS saying not to use the GT at all. I would remove both the
CR.
modifiers.
They didn't want you to use the CR either, which is a disaster code.
Yeah. So I would remove both modifiers and resubmit it.
Yeah.
Okay, so you got that. Remove all modifiers and resubmit it, and that most likely resolve the issue, Pat.
Do you know what place of service they used?
I don't know, but what place of service they're supposed to be using?
The place of service would not be 02, it would be 11 or 12.
Okay,
Right.
so Pat and the rest of you, you got that. Place of service has to be 11 or 12, okay? You see that 11 on box 24B. Okay.
11 being a clinic and 12 being home. Typically that's the patient's home, but the therapist is with them in that situation, or they're from the therapist's home if they're not working in the clinic.
Understood. All right, so you got the answer about GP. At this point for Medicare, for those e-visits, you do not need to use GP modifier. So we answered that.
Just a quick comment about ABNs. They're not necessary, but we recommend that you do get them. Is there anything else to say here, Jeannie or Mary, on this point?
No.
Okay. So here's just some general applicable coding rules for any of the services on box. You want to cover this, Jeannie?
Yeah, there was some confusion earlier on referring to the boxes on the bottom of the CMS form as place of services. It has nothing to do with the place of service code 11, 12, or 02. In box 32, you're supposed to report the physical address of the facility where the services are rendered. In this case, it's your virtual services. They're not rendered in your office, but you should be using your clinic's address in that box. Box 33 is your corporate address. If you have multiple clinics in one corporate address, that corporate address would be what goes in box 33. And that's for all billing.
What if you have one clinic location, but you use a different address for mail?
That would be your corporate address in box 33, your correspondence address.
Yeah, I just wanted to clarify that.
Right. And then the 24B, again, some of the payers are saying to use place of service 02 for the telehealth. Others do not want you to. They want you to use a modifier to tell them it's telehealth. Medicare does not want you to use the 02 for the virtual or the e-visits. So we know for sure on Medicare. The other ones, I would suggest you use the verification form.
Yeah, so
let's
show you in a minute. Let's make sure we get to that. Just real quickly, you know, the rules on this payer to payer are still kind of confusing. States are more than beginning. There's 37 states now that are saying, you know, this stuff should be happening at parity, meaning your in-clinic reimbursement rate for the procedure code would be the same under telehealth. And we know that we've been added to e-visits and virtual check-ins, but not telehealth, though they did add the procedure codes to telehealth, but not us as providers. So you can still, you know, bill Medicare patients as a cash service or self-pay. And the MCOs can kind of do whatever they want. So they don't necessarily have to follow the Medicare scenario. And then, you know, it's not, you know, the ABNs aren't necessary, but though we do recommend that you have them as just kind of a safety net insurance policy kind of thing, just to establish that there wasn't confusion on the part of the patient. And we are seeing now that more of these national payers are starting to cover the patient's copay. At first, it was a little confusing as to whether or not they were just saying a copay wasn't needed, meaning that it was going to take revenue away from the provider. And I believe that what's really happening is they're actually, the payer is covering the patient's copay. Any other points on that?
I just want to tell everyone that you can type your questions in the question panel, and if you guys like to actually speak or ask a question verbally, I'm going to open the microphones at the end of the meeting. There's a question: if they do not pay their copay, then we lose out, right?
Yeah, I think what's happening though is the payers are covering the patient's copay. They're not saying that the patient doesn't need to pay one. They're saying they're going to pay it for them.
Yeah.
I think the only problem with that is that most people, I understand, are collecting at the time of service. So
Right.
basically, if the payer did cover the co-share, then you would have to reimburse the patient.
Yeah, agreed. I think that money flow direction is a little easier. So
may I actually, if you don't mind, Bob, because we get all these questions that have to do with, okay, will this insurance pay for the copay? Will that insurance pay for the copay? I think that part of what you have to do is you have to verify.
yeah,
Really.
yes, and that's exactly where we're at. We really have to do we can see the verification form now.
Yes.
Yes,
Okay.
we can. Yes.
So we
and all of these documents, including Mary's presentation, Bob's presentation, and all the forms, they have been already uploaded under the resources tab of savephysicaltherapy.com. Okay? You can get it there.
We've taken all of these, you know, kind of confusing things and tried to put it into a form. And if you walk through this sequence of questions, you should pretty much have what you need to know what individual non-Medicare payers are doing with this. So this form is, you know, is the sequence of questions. It takes you right through the different options. We thought through this in a way of how the question gets asked to kind of clarify the confusions. What I think, and Jeannie, maybe you can explain this better, or Mary, the people that you're going to talk to aren't going to tell you how to do the billing. They're just going to answer questions. So you can't say, you know, should I bill this code or use this place of service, you know, or you kind of need to ask the questions this way so that you can sort out what's needed and what's not.
Yeah, I wanted to add that this form should be used in addition to your normal verification form. So you're still going to ask about the deductibles and the co-insurance and the copay. And at that point, you can ask if it's being waived for the type of service that you're rendering. And as far as what Bob just said, many times you will get a representative on the phone that does not know what you're talking about. So in that case, you know, I would ask to speak with a supervisor or ask her to find out where you can find the rules and regulations in writing. If they have it somewhere on their website or on a newsletter, have them refer you to something.
We do have some other miscellaneous things that we've found out along the way about coding. I don't really want to take all the time to talk specifically about every one of these scenarios because this is available to everybody. But as we find out a specific payer scenario, we're kind of putting it down. And so there's a little summary of some miscellaneous coding requirements by payer that we've as we encounter them as well. Mary, do you want to talk about documentation related to virtual services?
Sure. Do you want to share your, let me have the screen?
Sure.
I probably can do this. Okay, I probably can do this from your slide. I mean, basically, when we're talking about the telephonic virtual service that we are, one, it is supposed to be initiated by the patient, and that is to be documented. Now, we know that they're going with the light hand, so how you state that is important. Patient was advised of available services and the patient chose the telephonic assessment and management, something of that nature. We also have to say that they consented, and consent forms are in many cases being kind of brought up on the screen. The patient can see that, and they're handled that way many times. But a verbal consent is approved right now during the pandemic. You do have to look at whether your state will allow that. We went through and looked at all the states, and some of them do require a written confirmation of consent, but that it doesn't, none of the ones we've seen said they have to be rendered before services. We need to, on the telephonic documentation, we need to record the amount of time that we were, what the conversation was about, very much like you would explain the treatments. Then if there was conversation that led to an action to be taken by the patient or an action by the therapist or both, that needs to be recorded. If you are, now I might not be able to do this without my notes, but I think that what we have to be careful about when we're documenting is failing to show skilled services or failing to show clinical decision-making. That's going to be critical as to whether we're going to continue to have the availability of these virtual services. As it relates to check-in, again, the documentation consent is important. The establishment of the virtual service request by the patient. Again, anything that the patient said that would change and alter treatment. So you want to make certain that you do have what your response was, what are you changing if indeed you have to change something, what is the patient supposed to do based on the interaction that you had. So that's, and it's pretty much the same for both of them, although the time for the telephone assessment is different than for the virtual, because virtual you have one code and the time doesn't matter, although I would tell you, you probably want to record it. On the telephonic, you have 3 codes, and so recording the amount of time of the call would be much more important and certainly required.
Yeah, under telehealth, it's really about documenting similarly to what you would be doing in the clinic.
Face to face, right?
Because you have to show that the outcome is similar to what would have been accomplished in the clinic. And in the virtual check-ins, it's really about documenting what other course of action is needed in terms of service or visit. And then the e-visit is about the just showing the clinical decision-making that was accomplished during the encounter. Awesome. So I think we already mentioned this, all the co-shares of whatever sort are going to apply. And the reimbursement, we've already talked about that. A little bit about platforms. This isn't really a technology discussion, but you know, you do want to make sure that if you're not using a HIPAA compliant platform, that you're telling the patient right up front that that's true, so that, you know, you can document that they wanted to go ahead with the encounter anyway. You know, there's all kinds of platforms that are being used with lots of different scenarios. Some are typical. I believe there's a general strategy here about looking at the platform in the context of how you plan on using this going forward, and whether or not it's something that would survive a rollback of these relaxations, you know, regulations, and so you're not going to have to upset and start over, start from scratch on how you're using what you're using. So there's a variety of platforms. You know, we're not platform experts, but I do think that, you know, I think when practices kind of go into this as a new thing, they really focus on their side of the platform, and how they communicate to the patient and how the patient sees them and all that. The biggest problems are on the patient side. What kind of scenario does the patient have on their end is also something to really consider and look at. Are they trying to hold their iPhone up while they're doing the encounter? Do they have something to place a camera on? What's their internet speed? Do they even have the ability to see, you know, a video?
Is this Demi's phone?
So, you know, it's platforms are a big, you know, big part of it. So to wrap this up, you know, considering virtual services really it's part of your top line support strategy. It's how do you support revenue? That's the name of the game. That's the biggest challenge that we have right now as an industry. So is this a new revenue source, or is it going to be complementary to something that you're going to continue to do on an ongoing basis? And, you know, consider it as part of the patient care strategy too. You know, it allows you to stay connected to patients where otherwise you might not be able to, because they're not coming to the office. And you can use the less expensive, less time consuming, easier accomplished versions of virtual services as a way to stay connected. And maybe, especially with older patients, possibly, you know, that's a bridge to getting them into the more, you know, technically complicated and logistically difficult telehealth visit, you know, as a whole. So make sure that you're doing a proper verification in addition to what you already do. We'll share that form, and feel free to use that however you feel, you know, fit. You do have to ask the right questions. You want to identify issues with getting paid, obviously, like any other verification or authorization scenario, and make sure it's all properly documented. Adopt a platform with a longer term strategy in mind, and don't forget about the patient side problems, and be proactive with the patient on establishing what kind of scenario they're going to have on their end in order to have a successful encounter. And then, you know, look at this as, I know there are practices out there that are kind of jumping all the way to the other side, saying, I'm not going to have an office anymore. I'm going to only do this. And obviously that's your all decision to make. But I believe nationally what we're seeing is that this is going to be an integrated model going forward, where it's used to support and in conjunction with traditional visits, because I think the only thing we can say for certain is that whatever normal used to be is never coming back. So this is us. This is what we do. Comprehensive revenue cycle services. We are a billing service provider, but we do that with the context of where the focus on revenue cycle as a whole. We do evaluate effectiveness of revenue cycle as the first step. So anyone who might be interested in figuring out or understanding from real data how that's going, we're happy to do that. And last thing, I just want to make sure everybody's aware of it, because we have put together a PPP loan impact assessment and the math on a 2020 cash flow for the entire year based on questions that you would answer in a Google Form survey. So It's been really, really well received. It's been very helpful to a lot of people that have already done this. It's free. We're not charging anything for it. We just want to help you do the math on figuring out what's needed in order to get to the other side of the gap. So, you know, we got a bridge that's got to go all the way to the other side. And for the vast majority of practices in this country, this loan does not get you there. So we have to look strategically at how to build the rest of the bridge. And so it starts with good data. It starts with documenting, with really understanding a scenario. And there's so many moving parts that you want to start with understanding a specific scenario and see how that plays out. So far, with over 100 practices that have done this, we see that practices are expecting to lose a total of about 40% of their revenue between now and the end of the year, and 35% of their workforce. It is a lifeline, but it's not the only thing that needs to be going on in terms of strategy. And now is the time, especially because we're going to have more time to really look at your infrastructure, your processes, the things. This is the time to go into your businesses and improve the stuff that you never had time to do before, and do it, because when you come out of this, I think you're going to be really busy. There's a pent-up demand for our services as physical therapists. It's going to come out. You know, this will end. And, you know, we can help you in a number of ways. So that's my contact information. If anybody wants to look at any of this stuff, we have, you know, we're connecting with a lot of practices on that, and I'm happy to help however we can.
Thank you, Bob. A couple of questions that we can answer very quickly, I believe. Can a physical therapy assistant treat with telehealth?
Yes, as long as it's authorized or approved service by the payer.
How about e-visit?
So the same. You have to ask specifically PT, OT, PTA, OTA in your verification.
But what about supervision for the PTA?
Mary?
You know, I have not heard that they have approved PT assistants to do telehealth. I have not seen it in writing, nor have I heard it anywhere. So I can't give you an answer. I apologize for that.
Yeah, obviously the supervision requirements were based on physical locations, and that doesn't happen with virtual services. So.
And multiple people are asking, has any physical therapist thus far been paid for an e-visit from Medicare? Do we have any example of one therapist that has been paid for an e-visit from Medicare?
I am aware that they have.
Okay, all right.
It is not a windfall.
Good. All right. Let me see.
Can you see my screen?
Yes, we can see, Mary, your screen. Let me say very quickly that Vanessa, your question actually about infection control and everything will be answered right now by Mary. So don't worry about that. You'll get the information.
Right. I wasn't sure how much time was allotted for this session because there were a couple of points I wanted to make about documentation, and then I can certainly go right into OSHA. But what is the time frame? How much time are we scheduled for?
Mary, here is the thing, okay? We say that this is supposed to take an hour. Usually they take 2 hours, okay? So please take as much time as you need. If people, they won't be able to stay on, this will be recorded and it will be on the website. So go ahead and present all the good stuff you have for us.
Well, I'm just going to touch a couple of things that I left out on documentation. When we're looking at excuse me, I'll make sure you know what we're talking about, that we have, can you see the whole screen? There you go. Okay, the telephonic assessment and management. You do also need to document that you have not provided services within that 7-day window we talked about of a face-to-face encounter, and also not any billable procedures within that 24 hours. So that is an important thing to know on that telephonic assessment and management. When we get also to getting down to what you're getting paid, the telephonic services as well as the virtual check-in are sometimes therapy. And you know, that never meant anything to me until I realized that if it's sometimes therapy, that means we have no multiple procedure payment reduction. So that's at least a little more money. You can only bill 1 unit for the telephonic visit. So even though you have 3 codes, you may not do multiple procedures or units billed. And again, we talked about the place of service that you would be documented on the claim form. When we get to, I think I covered everything on the telephonic documentation that I needed to, but when we get to the check-in, you know, for it to be as poorly reimbursed as it is, and we're not looking at much money, but it doesn't have the multiple procedure payment reduction, so it's more than if it was face-to-face. You have to have the established patient documented, the consent. Again, you can use several different types of virtual services. You must have direct interaction between yourself as the therapist and the patient, although they could have a caregiver helping them with interaction. So that's a real important thing. As I said, it's sometimes therapy, so that's important, 1 unit only, but it only has 1 unit, and the place of service is where the PT made the call from. So I'm not going to get into the e-visits. I put it in here so you would have it. So we're gonna get to what is causing our feathers to be kind of tousled. As you know, and this was circulated, I believe, last week, the SBA loans do have a caveat, and you sign the loan, and when you sign the loan, you are stating that you are in full compliance with OSHA. And OSHA can, at any time, require you to modify your business or your facilities to make sure employees are protected. So in our case, that is social distancing, limiting the number of patients or people that are in the clinic at one time. You can be fined and forced to cease operations if you do not comply. And it's very important for you to understand that your signature is the attestation. It's just like we used to say about the KX modifier. If that goes on the claim and you are the therapist that has the NPI on there, that you are attesting it was necessary and that you were in compliant. So the same thing holds for this. Many therapists.
Can I ask you a question on that?
Sure.
Is that condition, OSHA can require businesses to modify facilities, is that always applicable whether you've taken a PPP loan or not?
Yes, because we are supposed to be compliant with OSHA in everyday situations. So if you have not established an exposure control plan under bloodborne pathogens or a hazard communication plan, then you are not compliant with OSHA. And at any time, they could have come in, surveyed you, and you would have been subject to fines and a number of other things. I personally am aware of therapists who have had an OSHA surveyor come in, and one therapist was very compliant and the other therapist wasn't, and they were fined. Now, OSHA's a little more kind than some surveyors. They let them pull things together pretty quickly without, and if the corrective action plan occurred in a good period of time, then they waive fees. But you know, if you don't make the attempt, you could be subject to those fees and penalties.
Yeah, and so signing for or submitting a PPP application doesn't increase any kind of requirements in regards to OSHA. They're already there anyway.
No, not at all. They're there, but in most situations, you haven't signed away that, hey, I would like to have this loan, and to be eligible for the loan, I know I have to be compliant with OSHA. So that's the important difference.
Okay.
So infection control, you're dealing with health and education, you have to monitor and you have to administrate it. So typically what we'd see in an infectious disease and control management plan is that you have major employees, and again, OSHA takes care of employees. And that is a critical thing for you to understand, that it's not that they don't care about patients, but this is about the employee, the safety of the employee. So they need to understand what are reportable diseases and conditions. Before the pandemic, that was there. So they should have been reporting whether they had, strep throat, or whether they had the measles, or whether they had shingles, or whatever it is. So the types of symptoms that occur with the reportable diseases, things that require immediate reporting as well as action taken. So maybe the employee being asked to go home and not return until the symptoms are there. And again, of course, we're talking about COVID-19. We know what we have to do with that, but this was in place before that. And work restrictions apply to employees, but there could be patient restrictions. So if a patient comes in with a condition, or they bring their child who is out of school because they have strep throat, or because they have the chicken pox or something of that nature, there definitely are mandates to restrict their presence. So when we look, oops, sorry, didn't mean to do that. The coronavirus, we are required to educate our workforce because, again, this has significant implications. We should be doing screening. I just saw a very nice screening tool that was put out by CDC just recently, and it had some good directives. So they have a decision tree that will help you work with your employees. They've suggested it, as well as we promote screening of your workforce. Temperature, complaints of cough, shortness of breath. Now the taste and smell dysfunction is also something they are talking about now, gastric problems. So when this all rolls out, we'll know what all the symptoms are, but right now you want to screen for the conditions that we know exist. And also to modify operations. I don't know if anybody is on this call from California, but one of our clients from California was told they had to post a protocol on their front door. And they basically told them what the protocol should have, but everybody was probably scattered trying to find out what they should post. And they came out with a very nice protocol, which again, we can make available to you, because it tells the patient, sit right there on the door, the instructions that they have given them. So when we look a little further, we have internal and external disaster prep and training. So, the typical things, what happens, cardiac arrest, or if you have someone who is physiologically unstable, maybe they have uncontrollable diabetes, we are supposed to have evidence of training for evacuation, fire, bomb threats, natural disasters, man-made incidents, and of course, epidemics and pandemics. So we have a true life drill going on right now. So if ever anybody want to check off that we had a drill, you have had a drill. So there is no OSHA standard covering COVID-19. However, there are requirements, as I said, that they are talking about a lot now. Personal protective equipment. We have to use the appropriate PPE when we're treating patients. I know many of you have done without PPE because it wasn't available. But under normal circumstances, based on the disease or the product you're handling, bloodborne pathogen of some sort, you are to wear appropriate PPE. And also respirators are necessary to protect workers. I don't know too many clinics that have N95 masks, but there are some that do. And again, there is a respiratory protection standard rendered by OSHA. So they have temporary guidances right now out there, but I bet you these are going to be changed a lot after the pandemic hopefully is past. So here's a big one.
Quick question. What about the eye cover? We have to cover our eyes like with special glasses or no?
Well, that's part of PPE. So goggles, I want to tell you, if I was out there treating patients, I would just go in my garage and get my goggles, I think, if I couldn't get my hands on some. A face shield is excellent, but most people don't. But we'll talk about that, what should be available PPE in your clinics under normal circumstances. And goggles or face shields are certainly included in that. So bloodborne pathogens requires an exposure control program. The young lady who from I think it was Michigan, who said she had a survey from CMS for infection control. The things that we suspected were going to be asked if it happened certainly were the ones. And looking at policies and procedures was a big thing. She said they were looking for that. And this would be policies and procedures for your bloodborne pathogen management and your hazard communication. You have to make exposure determinations on your employees. Some employees under normal circumstances wouldn't have exposure to bloodborne pathogens, and so they would not have to comply. I don't want to say comply. They wouldn't be governed as tightly as clinicians are. So their exposure determination would be, there is no need for them to have additional training, that type of thing. Employee education, the surveyor did look for education and training, and that bloodborne pathogens is training is required upon onboarding and then annually. A lot of people do roll their infection control requirements that are for Medicare, if you're a rehab agency, into bloodborne pathogens because they are basically identical. We have standard precautions, and that it's not universal. Standard precautions require you to treat everything as if it is a contaminant. So, and certainly that's what we would do with handling items or touching a patient that we suspect or know has the virus. There is specific hepatitis B vaccination requirements under the bloodborne pathogen standard. I probably get asked that the most, and yes, it is required. You offer them the vaccination. They have the right to say no, but they can turn around and change their mind at any point and obtain the inoculations, and it's a series of inoculations, and the individuals as I said, can change their mind at any time. The employer is 100% required to pay for the employee's time away to have the inoculations, or if they do a titer instead of an inoculation, they are required to pay for the inoculations as well. There are a lot of details about post-exposure, and I'm sure we're going to see plenty of those coming from OSHA about, so let's look at the opportunities for exposure that occurred in your clinic. We're hearing over and over, well, one of my staff members went to see her grandmother, and she's been identified as infected with the virus. What do you do with that employee? So they're going to be looking at post-evaluation of how we handled exposures, not necessarily bloodborne pathogen, but infectious diseases. And then we have certain record keeping requirements as well. So the hazard communication is a piece that we kind of forget about a little bit. A lot of therapists do not realize we must have a hazard communication plan, and we have to monitor and evaluate it as well. onboarding education is required, and then education as you change the products that you use. Someone asked me this morning, well, we only have disinfectants. That's probably the only thing that's hazardous in our clinic. And I said, they'll get me one of the items that you use in your clinic that's, you know, maybe a liquid or powder or whatever, and turn around, look at the back of the label. And if it says, you know, if spill, do this, if inhale, do this, if it's on skin, do this. Any type of hazardous warnings, definitely it's a hazardous substance, and it should have a safety data sheet, and it should be listed on your hazardous substance list. We also have, back in 2013, they changed the material safety data sheets to safety data sheets, because that's what is done elsewhere in the world. You have to have them for all your products, and you have to have that product inventory posted again. Training, as I mentioned, and again, there are specific record keeping requirements we have. So when we try to carry out our exposure determination, how do you do this with an employee? You know, you really shouldn't do it just by job title or description, because, you know, probably there's a lot of people who do a lot of things. Some we don't know about, some we do know about, but they don't really fit in their position description. So you're going to look at the employee's classification that has an occupational exposure, but you're also going to have to look at the tasks they do and determine whether they are have the potential for exposure. If they do, then you absolutely have to provide the bloodborne pathogen exposure and HAZCOM exposure to that individual, and carry out the training as required. This is what an exposure determination form looks like. I apologize, I had this slide was older and it doesn't have the right dates, but it does allow you to see what, you know, handling of sharps, handling soil linen, cleaning patient contact areas, all of those would be things that you look at as per the duties that are carried out and their position description. So if they do have potential, they have to be given the opportunity to be educated and to have the protective equipment, and that includes, you know, the inoculations. Standard precautions.
Mary, one quick second. Let me just say that real quick. I am getting a lot of questions in regards to if Mary has this in a manual that she sells this, because I want to give the answer to that. The answer is
sure.
Yes, and I just did include it in Mary's phone number, but you can check her website
sure.
also. But we use Mary's services, and not
you have our compliance program, right?
Not only we use the compliance program, and we have not only we're receiving a lot of stuff to train even our staff members and all that, but we're receiving very frequent updates through a private newsletter where she puts out all of this information, so we stay up to par. Actually, our staff members right now, that we have given them until the 17th of April to complete the updated OSHA program that gave us. It's a webinar they have to watch. There are 3 different exams that they have to take. We have the answer keys for the exams, and then there is a certificate that they get at the completion of the training. It's really, really very well organized, and at least this is something that we don't have to think about. You know, it's like, okay, they do it, it's done, out of the window. I don't have to worry about having OSHA compliance or not.
Right. Well, we do, our compliance program is made up of modules, clinical operations, human resources, HIPAA, business office, and environmental health and safety is where the OSHA part is parked. It is a very, very detailed, it is fully scripted. It gives you an opportunity through a questionnaire to answer questions that will then, through our cloud version, will customize your manuals and have everything in place for you. We do provide education, so we have webinars, as Demi was saying. We sent our clients out a webinar and then added a little bit of COVID-19 information, and because we wanted people to understand what the virus was, and we did that in addition to what they had available at the time. Just last week, we included the hazard communication video webinar, as well as the safety data sheet information, so that should OSHA come poking around, you have that extra educational tool. The other thing is the webinars are evergreen. So when things change, for instance, we were in the middle of updating our manuals, which we do at least annually, sometimes more because of regulatory changes. But we had updated this and got the information out regarding the virus so that everyone would have that additional training opportunity. So you have my phone number. Let me give you another phone number, because this is the person really you should talk to, is Alicia Mahoney, and that is Mahoney. And her email, which is the best way to go because you can jump on her calendar to talk to her. Her email is Mahoney, Mahoney, A as in Alicia, at bcmscomp.com. And that will bring you to her inbox. And as I said, when it pops up, you'll be able to get on her calendar. She has a Calendly scheduler. So that's something, if you're interested in that. We also do sell that webinar separately, and that's on our website, and you can just go right to our website and pick up that particular webinar if you'd like to. Did that answer the questions, Demi, you think?
Sure, yes.
Okay. All right, so we know about hand washing. I don't think I've ever heard people talk about hand washing as much as I have, but we've been talking about this for a long time. And the 20 seconds changed from 15 to 20 about 5 years ago. And now they're saying 20 to 30. And there are a lot of, there's a lot of information out there. You can just Google hand washing techniques and you'll get videos and all kinds of things. But do look to make sure the resource is one that you can trust. So the other thing that this surveyor was looking for, besides personal protective equipment, and I do have a list with it later on, they're looking for engineering and work practice controls, as well as housekeeping procedures. So do you have a log of what gets cleaned, when does it get cleaned, that type of thing? And also the education of the OPIM, which is other potentially infectious materials, and how you use PPE with that. So they're looking at that. When we look at personal equipment, again, it's at no cost to the employee. Someone told me that, and this wasn't a healthcare facility, that one employer was charging their employees 10 cents a day for using a mask that they provided. And I would think that somehow or other OSHA would probably have a little problem with that. So here's your PPE, gloves, so disposable and sterile. And this is what you should have in your clinic. You don't need all of this times however many staff you have. I usually recommend that all of this, it's listed on here, be put into a container or two, and you have a full set of PPE. and then have the gloves that you're going to use the non-sterile gloves have various sizes, have a lot of people still use latex, but you need to have a non-latex variety for people who might have allergies to that particular substance. Mask, you should have surgical mask and a couple of ventilators in different sizes. The N5 ventilator has a fit test, which they are kind of waiving right now. They just, if you can get one on, they're happy. But when we started doing this back in, I'm not even telling you how long ago, OSHA came into effect with bloodborne pathogens in 1993. And they had N95 ventilators listed then. They call them respirators in some situations, but they were called ventilators in the beginning. But they had a fit test, and if OSHA came in and you hadn't shown that you documented that you properly fitted and taught people how to fit their N95s, you could be again sanctioned. Gowns, an impermeable gown, not patient gown. Eyewear, goggles, glasses, face shields, and resuscitation bags or pocket masks, those type of ventilation devices that will keep the patient and the therapist separate. Engineering controls and work practices. People think, okay, why am I doing this? We don't need to know the names of things. We just know we need to do it. Hand washing, that you do have hand washing stations. I've been in PT clinics when I've done a site visit that had no running water. And they had to run down the hall if they really needed to wash their hands. And that's a real problem. Hand sanitizing posts, sharp management. Yes, you need a sharps container. Even if you don't do dry needling, if you don't have any sharps that you know of, you still need a container because plastic, metal, all of those can be a sharp. Hazardous waste container, yes, so you have to have a biohazardous container. It can be small, especially if you don't have that often. It needs to be properly labeled. Eye wash stations, and yes, these are required. And you must have an eye wash station in your facility. Spill management kits will tell you what's in a spill kit. And again, segregation of areas. So that is a work practice control that can keep dirty or contaminated items out of the break room if you have one. We often see in PT clinics, laundry rooms and break rooms are combined. That's a problem unless you can minimize the area when you're eating so that it is sanitary. Housekeeping practices, again, now more than ever, you want to record what you've done. You want to think about every surface that could be touched. It's not just patient areas, but you could have someone who is a staff member who also may be a carrier or may have been exposed. So there are a number of things you want to make sure that you do from a housekeeping perspective. And using a CDC level disinfectant, what that basically means is it will kill tuberculosis and Hep B. So when you look at your disinfectant, you would look for that kill level on the container. Employees, again, have to have written schedules for cleaning and decontamination now more than ever. And you want to have that schedule available in the event there was someone that audited you so that you knew what was done, when it was done, who it was done by, possibly signed off on. They don't go to the level of you have to sign off every time you change and clean a treatment table or a plant. But you want that to be in your policy that states that you change linens, you decontaminate between each patient. And of course, now we definitely would. Also, that when you're doing your disinfecting, this is my platform. Do not use reusable cloths moving from table to table. You want to use disposable paper towels and they should be disposed of after you finish cleaning that table or surface or equipment. Do not move that contaminant from one treatment table to another. So what should go in a biohazard container? Right now, if you had someone who was identified as having COVID-19, obviously you're going to have to handle things that they touched or that they were on or that type of thing very carefully. You have to be careful on how you handle laundry with these, the same as you would with bloodborne pathogens. So having a separate bin for your clean laundry, your soil laundry, and a separate way of handling contaminated laundry. So you wouldn't put contaminated laundry in with soiled, because then a person may expose himself unnecessarily. Now I'm going through this really fast because I know y'all are tired. Environmental cleaning, again, per visit, per day, per week, per month, per quarter is really what you're looking for. Certain things that you could do daily and that you check off on weekly and that type of thing. So there are many, many lists, and that's one of the things we do provide with our compliance program. We have over 200 forms. So we have a form for just about everything. We're still working on some now that are coming up. So we just got our consent form finished last week. So we try to respond to the particular need of the moment. Appropriate disinfectants. I know that we did not use bleach in my clinic because it would eat up the vinyl. But if you don't have anything else, this is what you should do. Usually it's a 1-to-10 ratio, but you want to look on the CDC's website to see if they're recommending something else. Never use hot water. If you're using Clorox in laundry, it will break down to chlorine. So you want to use warm water. And then if you're going to do the second rinse, you could do hot water. As I said, you need a sharp container. Here's a spill kit. And again, this is not something you have to spend a whole lot of money on. You can get a kind of a large plastic bin with a lid. You can have your gowns, your masks, all of those types of things, shoe cover, utility gloves, you know, one or two of each, and typically it's 2. You would always have that available. And then if it is a liquid spill, how you're going to clean it up if it's on a hard surface, like using litter instead of something that is, you know, manufactured just for a spill kit and it costs you a fortune. So just there's some simple things to keep in a binder, label, in a bin, label those, and make sure your staff know that where it is. That's a question many OSHA people look at, asking you, show me where your sharps is. Sharp container is, show me where your biocontainer, do you have a spill kit, those types of things. Typically they don't ask employees a whole lot of things, but they will ask like that. They will watch how linen is handled. They will ask you where the fire extinguisher is, those types of things. So they can ask your employees things during a visit. Hepatitis, as I mentioned, it is a requirement that you offer at no cost the hepatitis inoculation and or titer to determine whether this person needs to have the vaccination series. And we're going to go really, really fast now. Hazard communication standards. We have to have a list of the hazardous materials, as I said, and you determine that by the back of the container or looking up the product on the website. Manufacturers are required to have SDSs. So you are going to have a safety data sheet for each of the hazardous substance. You have to label them properly now, and that doesn't mean writing with a marker alcohol or writing with the marker disinfectant. You have to use the official label, which includes pictograms. And if you, especially if you are moving a product from a large container like a gallon of disinfectant to smaller spray bottles, they all have to be appropriately labeled according to the new SDS sheet requirements. And I will tell you that we were doing a site visit a couple of years ago, and I said, well, these containers aren't current, and they were large containers of disinfectant, and they said, well, we ordered a whole lot from our vendor, but they called the vendor and said, do you have the properly labeled containers now? And they said, no, that's your problem. And that is what they said. This was a very, very well-known company too. So you might not always get cooperation from some of the companies, but that nevertheless, you still have to do it right. So the chemicals, most people think it's just disinfectants, and most of the time it is as it relates to really caustic things. But if you have a pool, you certainly have caustic materials that you work with all the time. So OSHA does have specific record keeping and reporting. And of course, if you have a confirmed case of COVID-19, there is a way to handle how you report this. Most of the time, you should go directly to your Department of Public Health for the state guidance, because each one deals with a different level of infections in the state or the area. We have things to report if it's work-related. So if someone does acquire the virus while working because they were exposed to a patient, this would definitely be a work-related illness. And also there are certain medical treatments beyond first aid that you have to report. And most of those are serious, days away from work, that type of thing. So now these are really a far stretch, but we do unfortunately have, we've had people die in clinics, certainly not routinely. It could happen now with what's going on, but you have to report work-related fatalities, injuries or illness that cause a loss of conscious, days away from work, restricted work, or transfer to another job, things that require medical treatment beyond first aid. Diagnoses in this would rarely apply to us, but this would be hazardous chemicals in the workplace that cause these things, and needle sticks and sharp injuries. So we are in, as private practices, we are in a partial industry level that says we do not have to post the OSHA 200 and 300 forms, but we would have to report these particular situations to OSHA as you would on a form. So that is as fast as I can go with environmental health. There's a ton that I did not cover. If you are interested in our compliance program, again, please contact Alicia Mahoney. If you are interested in the webinar for education for your staff, it is what we call evergreen. So we update it as regulations change, and it's something that you can use for education over and over and over for your staff, whether they're onboarding or whether you're trying to meet your bloodborne pathogen annual training.
Thank you, Mary. My goodness, it's so amazing because both you and Bob put together such amazing presentations that the people who stayed until the end, they really got a major education tonight, which is really, really awesome.
It's our pleasure.
Thank you, Mary, so much, and Bob, thank you so much for all that you are doing and your contribution to the profession. And I have to say, Bob, the amazing work that you are doing with the form that people can fill out, and you can help them with guidance. And Mary, all of the amazing work that you do to make sure that we are staying compliant it is really amazing.
Thank you.
Definitely at this point in time, when people are going to have um, time in their hands without seeing necessarily patients, and having the funds from the funds from the PPP loans, it is the time to look at various things, to look at, okay, how can I get my revenue cycle fixed? How can I collect my accounts receivable? And how can I plan for my not just survival, but really expansion until the end of the year? And at the same time, how can I remain compliant so that I can do the right thing? So and now that we have the extra time, those are really areas that we have to look very, very seriously. So thank you both very much. Before we close, I would like to show you real quick on my screen here. If you are looking for a good HIPAA compliant platform, we are working with, you go to teleptforme.com. We're working with the Better PT platform. And what we like about this platform is the fact that it can help you also with marketing. So we like that feature very much. For training of TelePT, telerehab, hands-on seminars, this is our organization, so we do have a direct financial benefit for disclosing that. We have this great course. It's only 5 hours long, and you can get certified in TelePT. And definitely, please join our effort. Join the pt4heroes.com and help the people who really need our help right now in the front lines of COVID-19. Costas, anything from you?
No, just thank you, Mary and Bob. The bottom line is that there is so much work to be done, but thank you, because without your knowledge and your input, really we're just totally like in confusion. So we need somewhere to grab and start moving forward. So both information in billing and compliance are extremely important with this scenario that we're going through right now. So thank you both.
You're welcome.
So
Our pleasure.
Thank you all. And I'm going to close tonight with the video from the PT for Heroes website.
No one asked them to do it. It's their sense of duty. It's their humanity. In the front lines, saving lives. You are our heroes. And the physical therapists of our nation are standing next to you. Working together, we win. Visit www.pt4heroes.com.
So thank you very much and have a good night, everybody.
All right. Thank you.